Good morning, everybody, or even good afternoon, depending on what time of day you're listening to this. This is the second recording of Lecture 2. The first lecture, the sound corrupted after about 5 minutes in, so I'm redoing this lecture, and hopefully it will be better this time. Okay, so we're going to really focus on the beta-lactam antibiotics in this lecture. I just want to finish off a few things before we get on to that, which will follow over from lecture 1. One of the things I wanted to talk about first is pharmacological issues. That is how you get the drug into the right place in the body where it's needed, where the infection site is, at the right concentration at the right time, and what happens to it. And some key ideas you need to think about are the so-called minimal inhibitory concentration, the MIC, or the minimal bactericidal concentration, the MBC. So the MIC is the amount required to prevent bacterial growth. The MBC is the amount required to kill it, and in general, the MBC is higher than the MIC. But it's a very important first kind of measurement of a potential drug compound. What is its MIC? And as a rule of thumb, you should be looking at maximum of micrograms per milliliter concentration for a good antibiotic MIC, much above, say, 4 or 5 micrograms per mil. Normally your compound is not sufficiently active. And the MIC, I think you can look up for different species and different situations. And the dose we need to think about is, of course, you're given a dose of antibiotic. You might be given, I don't know, an IV dose of maybe 1 gram of an antibiotic, and then that, of course, is diluted in your blood, in your serum, in your lymphatic fluid, and then taken to where it needs to get to, and all the time it is also being metabolized and eliminated. So the key is to choose a dose and a means of administration such that it gets to where it's needed at a concentration well above the MIC. So we have to concern ourselves with drug absorption and to think about what affects the absorption in different parts of the body. And this is complex and, as it says here, not always well understood. In general, highly vascularized parts of the body have good drug absorption. So parts of the body which have a good blood supply, like the liver, most tissue, particularly in the upper body, have good drug absorption. Where life gets difficult, bone is often very poorly vascularized, so trying to treat a bone infection can be very, very difficult. If you have poor circulation for whatever reason, perhaps type 2 diabetes, getting drugs to where the infection is needed, particularly in the feet and toes, can be a big problem, which is why many people with type 2 diabetes can suffer nasty foot infections. A very brief one slide on pharmacokinetics really is to think about this mnemonic, the ADME scheme, which is a useful way to think about what's going on when you have any drug administered, not just antibiotic. It's absorbed, so how do you get it into the blood? Is it oral? Is it by IV administration, or whatever? It's then distributed throughout the body, normally by, for example, blood, but also lymphatic drainage and other fluids. It's then metabolized, generally in the liver, into more water-soluble compounds. The basic process of that the liver does when it removes substances is it makes more hydrophilic, so it can be excreted more efficiently. And of course, it's excreted through the kidneys. So we also have to concern ourselves and worry about sometimes liver toxicity, hepatotoxicity, but also nephrotoxicity, toxicity in the kidneys. Quite some potential new antibiotics fail in clinical studies because of nephrotoxicity. And then that brings on to excretion, so elimination, and that's something we also need to worry about, how long that takes, and in general, how long and at what concentration the drug is in the body for. So this is the ADME scheme: absorption, distribution, metabolism, and excretion. This graph here shows the kind of biphasic nature of decrease in drug concentration after this is an IV bolus. This is an injection of a drug at this time point here. You see we have a rapid decrease in concentration in the distribution phase as it's distributed around the body, and a slower elimination phase as the liver and kidneys remove it. When thinking about drug design, it's sometimes perhaps difficult to think where to start. And in general, where you start is you look at natural compounds which are known to have antimicrobial activity, or sometimes you try and do high throughput screening, where you just screen millions and millions of compounds. This is an approach that, for example, Glaxo have used. Lipinski noted an empirical correlation between many effective drugs, not just antibiotics, but in general, particularly antibiotics, and for example, number of hydrogen bond donors. And he said that it appears that molecules which have fewer than 5 hydrogen bond donors, a molecular weight of less than 500 grams per mole, a log P less than 5, so that's not too, that's fairly water soluble, and fewer than 10 hydrogen bond acceptors tend to dominate. But it's not really a rule, it's an empirical observation, so I would almost cross out the rule and say this is an empirical observation. And it's, while generally true, there are, of course, as ever in science, plenty of exceptions. So let's look first at a molecule obeys the rule. This is penicillin 5, phenoxypenicillin, and you can see it has 351 grams per mole. It has one hydrogen bond donor, which is on carboxylic acid there. It has 5 hydrogen bond acceptors. That would be on the carbonyl oxygens, the nitrogen there, and so on and so on. And a log P of 2.09, so it's fairly water soluble. That obeys Lipinski's empirical observations. Here's vancomycin, another effective antibiotic, and you can see immediately that it absolutely disobeys Lipinski's rules on pretty much every level. Large molecular weight, large number of hydrogen bond donors, large number of hydrogen bond acceptors. Although it is, I think, fairly water soluble, so yeah, probably at least obeys the log P rule, if nothing else. So problems with prescribing antibiotics. Antibiotics tend to be given to about 30% of all hospitalized patients, and also many patients are not hospitalized. I'm sure most of you listening to this have had antibiotics at some point in your lives. But also used extensively in agriculture. They allow us to crowd animals together to have factory farms, but essentially factory farming would not be possible without antibiotics. Because of their widespread use, we've of course seen antibiotic resistance, the emergence of antibiotic resistance, and this is potentially becoming a global health emergency. When selecting an antimicrobial agent, you need to consider all sorts of issues. For example, the MIC, the MBC of the agent for a particular target bacteria, but also the infection site where you're trying to get to, and toxicological and other factors. And the ultimate goal in choosing a drug, of course, is that you want a molecule that's less toxic, has the least potential to cause toxic or allergic reactions for host patient. And of course, this is true of any drug, but also is highly effective. So generally a drug that has a very low MIC, you can prescribe it, administer it at very low concentrations, but is effective at doing what you want it to do. Okay, that's pretty much the introduction to the course over in terms of pharmacology, microbiology, etc., etc. We're now going to move on to the chemistry side of things, and particularly concern ourselves with potential target sites for small molecule antibiotics in bacteria. And I think this slide I'm showing you here is one of these slides that's really worth learning. It summarizes in one single cartoon, not a very good cartoon, but it does the job, the principal target sites, the 5 principal target sites in which you can think about designing drugs to act against. And in general, what we're doing here is we're exploiting, as I already said, the difference between the prokaryotic cell and the eukaryotic cell. Difference in the ribosome, difference in the DNA, difference in the plasma membrane, etc., etc. So just quickly go through these. We've got molecules which inhibit cell wall synthesis. And you might say, well, why does that matter? The point is that most bacteria, with the honourable exception of perhaps the mycobacteria, which cause tuberculosis, reproduce very, very quickly, typically every 20-30 minutes, and which means they're constantly having to make new cell wall. So if you can inhibit the process of cell wall synthesis, you have a very good chance of having an effective drug. We then have, within the cell membrane, within the cytoplasm, we have three mechanisms that we can concern ourselves with. We can inhibit DNA replication, particularly inhibiting enzymes which are involved in the DNA making copies of itself. And of course, every time the bacteria divides, the DNA, the chromosome, needs to make a copy of itself. The other thing a bacteria does, like any cell, is needs to make proteins, essential proteins that allow a cell to function. It does this via transcription and translation in the ribosome. The transcription is where the DNA, an RNA copy is made of a DNA or part of the DNA. That's the mRNA here, messenger RNA, and then it goes along to the ribosome and is translated into the protein. So this transcription process can be inhibited, as can the translational process in the ribosome by a number of different drugs. For example, for translation by chloramphenicol, rifamycin, tetracyclines, etc., etc. Okay. The fourth method of direct is a direct entry to a plasma membrane. This is basically blasting holes through the membrane, and this is what the polymyxins do. For example, polymyxin B, polymyxin E, colistin, these kind of drugs, they actually directly interfere with the plasma membrane. And then there's another class of drugs which we're not really going to consider in any detail in this course due to lack of time, but these are molecules which inhibit the synthesis of essential metabolites. And these include the very early class of antibiotics, the sulfonamides, but also more commonly used trimethoprim, you see here. Okay, let's first of all concern ourselves with molecules which inhibit cell wall synthesis. Let's have a quick look at the cell wall before we go on. Cell wall, like we see here on the outside of bacteria, is generally sticky, which means it contains lots of peptidoglycan. It creates a capsule. This slime layer of peptidoglycan is kind of loosely attached around the side. It may have pili here, what you see here. These are so-called pili, or it may not. It may have flagella, what you see here, which allow the bacteria to propel itself to swim, but again, maybe not. Staphylococcus aureus, very important clinical pathogen, has no pili. It also has no flagella. Another interesting bacteria, Proteus mirabilis, which causes many urinary tract infections, is a very amazing molecule which can change its shape and structure, but has flagella that allow it to swim, allow it to do so. And this capsule nature of the bacteria helps prevent it being eaten up by immune cells by the process of phagocytosis. And of course, it basically provides strength. It means the bacteria can survive in isotonic or of course, it's happy in an isotonic environment where it has the same ionic strength inside as outside, but it can also survive in hypertonic or hypotonic external solution without falling apart, and that is an important point that we'll come on to. The primary classification of bacteria from a microbiological perspective is the so-called Gram stain. And the Gram stain was invented by a scientist called Gram, so it's also positive G, please, never small g. And I can't remember when he discovered it, which is slightly embarrassing. I should know this, but I'm sure you can look it up on Wikipedia or something like that. The Gram stain is a very simple process, and it's a very easy thing to do. But it's often a kind of microbiologist's first go-to look to see what they're dealing with. What it involves is taking bacteria, normally you allow them to attach to a surface, and you add a dye called crystal violet, which is an organic dye. It has a deep purple colour, and you add it for 30 seconds, then rinse water off, rinse water over it, and then you add iodine to help fix the dye on there. Then you wash in ethanol and acetone to remove any non-bound dye. Okay, and then following rinsing, you either remove the dye, in which case it's still gram negative, and you can add a counter stain, for example safranin here, and it dyes your bacteria pink because this will be gram negative. Or if you don't manage to remove the bound dye with 90% ethanol or acetone, then we call that a gram positive dye. And it's really a measure of how this crystal violet dye interacts with the cell membrane. Just to show you here, this is what it would look like on a microscope. We see a tube bacteria here. You see these look like bacillus. These rods here are gram positive. You can see they've taken up the gram stain very clearly. I'll just draw a little picture around it so you can see it. And then we've got these different bacteria here, which are probably chains of cocci, which are gram negative. You can see there. And they've taken up the counter stain for safranin and appear pink under the microscope. So why does it happen? So what's basically happening is the gram stain allows you to identify the structurally different nature of the two classes of bacteria, gram positives and gram negatives. The gram positives have an inner cell membrane. This is inside the cell. I'll just write it there so we don't forget. So inside the cytoplasm, inside. I'm not very good at writing in Excel, as you can see, but I'm doing my best. Right inside. So we have a lipid bilayer here. The kind of thing that Karen Edler will have lectured you about, I'm sure already, which is self-assembly phospholipids with transmembrane proteins contained within inside. And bound on top of this lipid bilayer is a big thick layer of peptidoglycan, which you might also call slime. It's a polysaccharide, and this thick layer of peptidoglycan is anchored onto the lipid bilayer via various teichoic acids, for example, lipoteichoic acid. And this gives the system some structural stability. That's a gram-positive bacteria. You can see how it looks there. A gram-negative bacteria is really rather different. It has the same internal inner lipid bilayer that we see here, that we see before, but now we have an outer lipid membrane, an outer lipid bilayer with pore in protein channels, for example, which allow the bacteria to communicate with the outside world. And we have a thin layer of peptidoglycan, so it still has peptidoglycan, but it's much thinner and it's sandwiched in between the two lipid bilayers. It's structurally quite different and doesn't take up the violet the same way as a gram-positive, and hence when you stain, it doesn't take up a gram stain, but it takes up a counter stain for safranin. Looking in more detail at gram-positive cell walls, what we can see here is we have these teichoic acids, which are these polymer type molecules which anchor, so these are shown here in black, and the lipoteichoic acids go into the lipid membrane and react as a kind of structural scaffold that anchor peptidoglycan. So peptidoglycan is the slime layer, if you like, a polysaccharide, which is I'm showing here, across here. Okay, so they anchor the peptidoglycan to the lipid bilayer. In gram negatives, it's quite different. We have, as I already said, a much thinner layer of peptidoglycan. You can just about see that there. One of the interesting things about gram negatives is they tend to have liposaccharides, for example, lipid A in the outer membrane, and these are often known as endotoxins. They're very immune stimulating, and the immune system sees these guys and often goes a bit crazy. It's been programmed to see such lipopolysaccharides as evidence of bacterial infection. And this is, if you remember in lecture 1, we said some endotoxins are still toxic even in a dead bacteria, and this is true for particular gram negatives. Sometimes you have to worry about toxic shock, for example, from dead bacteria. Okay, and we already said that we have these porins that go traverse through the outer membrane, allowing access to the outside world inside the bacteria. Looking now in more detail at peptidoglycan, as I already said, as I already said, it's a polysaccharide. It contains two sugars, N-acetylglucosamine, which is this guy here, that's NAG, and that's polymerized with N-acetylmuramic acid, which is this fellow here. And these are long repeat chains of fairly high molecular weight. And we show that schematically here on this key, this kind of light pinky color is NAG, and the small purpley color is NAM. You see the NAG-NAM chains, they run for long polymers through the lipid membrane. But the important thing to note here, and it's very important to note, is that they have these pendant peptides and these cross links. We have so-called tetrapeptide, these 4 peptide side chains that hang off here in light green, and then we have these peptide cross bridges. These cross bridges are very important. They give the structural stability and strength to the lipid membrane. A bit like if you compare latex rubber, which of course is a very soft, well, it's a liquid in fact when you take it out of a rubber tree, but you can cross-link it, you can vulcanize it, you can make a car tire. It's still chemically similar, but you've used sulfuric acid in the case of a car tire to turn this liquidy rubber into a solid material. These peptide cross links do a very similar thing with this biological polymer, this polysaccharide. So drilling down into even more detail, we look at these pendant peptides. So here's our NAM-NAG. Remember, this is our polymer up here we've already talked about. That's shown diagram schematically here. And we have then these pentapeptides hanging off. Generally L-alanine, isoglutamate, L-lysine, and D-alanine. So that's these green guys here that you see here. Okay. And it's this L-lysine is very important. And you'll see why in a sec on the next page. The L-lysine, maybe not the next slide, the slide after this one, is attached to these peptide bridges that we'll look at here. And just to remind you, as I already said, every time a bacteria divides, it has to make new cell wall. Okay, and this process happens every 20 minutes. So if you imagine as a bacteria divides, it has to then create new cell wall, which is structurally to give itself structural integrity, as well as, of course, make a copy of its chromosome. Slightly out of sequence, but we will come back to this. Peptide cross-linker in a very short time. I just want to briefly introduce for you the 3 classes of so-called beta-lactam antibiotics that are used very commonly in clinical medicine: penicillins, cephalosporins, and mecarbapenems. You can see why they're called. You can immediately see why they're called the beta-lactam antibiotics. They all have this beta-lactam ring, which is a strained 4-membered ring with the amide group that we see there. So the penicillin class of antibiotic has this common structure. Obviously, for beta-lactam, as you would expect, has an amide and then an R group here, which is variable. But then we have a second ring, which is a 5-membered ring with a sulfur in, and then this essential carboxylic acid here at this position. And we'll talk about structure-activity relationships in a short while. So we come on to how penicillin works now. So I already said that we've got this link here on. These are pendant peptides already discussed: alanine, glutamate, lysine, alanine, and then we have these side chain glycines here. And for the process of crossing to take place, what happens is the glycine here, the terminal glycine here, wants to form a bond with the terminal alanine to kick off the second alanine here. So to form this structure that we have here. Okay, so the formation of this bond here that I'm just pointing out here. Now this is an enzymatically controlled process. Getting glycine and alanine to react under normal conditions is quite tricky, but an enzyme allows the process to happen. This enzyme has unfortunately 2 names for exactly the same thing. It's called transpeptidase, but also known as penicillin binding protein, or PBP. Now, transpeptidase and penicillin binding protein are exactly the same thing. So I'm afraid you will find in the literature and in your reading that they basically people interchangeably use the two words, which is very irritating, but that's life. So what it does is it mediates this linkage of a terminal glycine to the fourth residue of the alanine there. So it basically allows this reaction. It catalyzes this reaction here. Okay. So how does it work? How does it actually do this? There are two proposed modes of action, and I'm not clear at this point whether people have completely decided which is correct. So it's best you learn both, basically. Okay. So one idea is that it's an inhibition of a transpeptidase activation site. Let me show what that means. Okay, this is another schematic cartoon. Slightly confusing, this cartoon, because inside is up and outside is down, unlike we've seen before. So the cytoplasm is inside the cell there. Okay, there's our lipid membrane, there's our lipoteichoic acid, there's our NAMNAG polysaccharides, of course we have lots and lots of them. And then there's our pendant peptides, and then our pentaglycine linkage here. Okay. So as I said, what we need to do, what penicillin binding protein does, is it allows this cross-link to take place, this cross-link reaction to take place. That's shown broadly here. So penicillin binding protein, also known as transpeptidase, may come along. It creates an environment, an energetically favorable environment for this reaction to take place, kicking off terminal dealanine, what you see here. Okay, and that you've shown in yellow there is our pentaglycine chain. That's that boy there. Okay, and that's what we want to happen. Well, that's what we don't want to happen. This is what the bacteria wants to happen, but we want to inhibit this process. So one theory about penicillin is that it comes along, and we can see here it binds in the binding site of our transpeptidase, our penicillin binding protein, and it binds perhaps more strongly than the biological substrate, and inhibits the enzyme from allowing cross-linking to take place. That's one theory. Okay. So just a little bit about discussion about penicillins. They're a very important class of antibiotic, first discovered, of course, by back in 1928, but importantly isolated, and then the a synthetic of a biological synthetic process, large-scale manufacture was worked out by Florian Chain. Interestingly, Dr. Hodgkins in 1945 worked out their X-ray structure. And as I already said, I'll repeat myself a little bit. We have this beta-lactam ring, the acyl side chain here, and then this thiazolidine 5-membered ring here. And this R group here is variable. We can play with lots of different things there, which can confer useful properties when we come on to this. There are other beta-lactams, cephalosporins. It's an example. Here we have a 6-membered ring, otherwise structurally similar, same carboxylic acid group here. Okay. So what's the origin and shape of penicillin? It's been noted that it has structural similarities to a cysteine and valine amino acids when seen from kind of side on, which may be why they mistakenly is maybe why they bind to the penicillin binding protein so well. But there are many derivatives of penicillin all rely on the basic structural skeleton. Okay, so as I already said, proposed mode of action may be that it's misread. It's structurally not totally unsimilar to dealanine, which of course is what's required to is what the transpeptidase binds to allow the cross-linking reaction to take place. And that's dealanine. Dealanine, the natural substrate for transpeptidase. There, with penicillin, you can see, but at least in terms of a backbone, they are fairly similar. Of course, the natural substrate doesn't have a beta-lactam ring, but it may be why the binding site is also able to recognize penicillin in the same way as its natural substrate. The alternative mode of action that's been proposed is there's actually formation of a covalent adduct. But the fact this beta-lactam ring is so strained means it's fairly reactive, and that neighbouring hydroxy groups near the active site of the enzyme, this is the enzyme here for transpeptidase, can actually form a direct covalent bind, can directly bind penicillin or beta-lactam to the active site and effectively block the active site, so preventing therefore the alanine from coming into the active site there. Which either is correct, and I'm not entirely clear at the moment, which is, if there's a consensus, which is definitely the right mechanism, never mind. The outcome is that it weakens the cell wall of the target bacteria. The cross-linking peptide doesn't happen properly. And that's not necessarily a problem if the bacteria is in an isotonic solution. So isotonic solution have the same ionic strength inside as outside, not a problem. Where life gets difficult with bacteria is if you go into a hypotonic or hyperosmotic solution. So there's less salt inside than outside. The bacteria basically bursts out. Or conversely, if you have a hyperosmotic solution, so you have a high ionic strength outside, a lower ionic strength inside, the bacteria basically kind of crushes in on itself and gets very unhappy indeed. We did some work ourselves a few years ago, my research team, looking at combining various antibiotics together and what effect this had on bacteria. And my student Holly took some really beautiful SEM micrographs of a bacteria, and I just want to show you this. I think they're really pretty. This is a happy Staphylococcus aureus. You see it's a gram-positive cocci. We have this typical kind of grape-like structure here. So at low concentrations of antibiotic, so this is below the MIC, but still we start to see so-called blebbing. You see this kind of structural deformation of a membrane there. And as we increase the concentration, we basically cause cell death. So there'd be a bactericidal concentration here, and you can see here how deeply unhappy the bacterial cells look. They're not themselves. Thinking about the structure-activity relationship of the penicillins, which is basically the SAR, tells you what you can play with, what you can't play with, what are the essential molecular components that can't be played around with. Well, basically we need this amide. This can't be changed in a penicillin. The cis-stereochemistry here on beta-lactam is essential. There. A free acid here is essential, again with the correct stereochemistry there. And the beta-lactam is essential. Okay, and some kind of biocyclic system is also essential. If we have a thiazolidine, then we call the system a penicillin. As we already saw briefly, you can have other rings here, other cyclic systems. Doesn't need to be 5-membered, and then we call them a carbapenem or whatever. So in terms of things to play with, we can play with this R group here, which is very useful, and you can play with this ring here, which is also very useful. So let's look at some examples. Why do we bother with this? Well, the penicillin, the first version penicillin was acid labile, which means you put it into acid and it falls apart. And that's basically due to it's believed to be due to the ring strain of the beta-lactam ring. These 4-membered rings are very strained, and this beta-lactam carbonyl here is unusually reactive. Generally speaking, these amide carbonyls are extremely stable, but in a ring system like this, a strained ring system like this, they tend to be unusually stable, unusually reactive, I should say. Okay, so what can happen is you can have neighbouring group participation, where side chain over here can basically cause self-immolation. This is catalyzed by acid. So, but it's believed, this is what's believed to happen. We have basically acid catalyzed hydrolysis of the ring, either by water or in some cases by the neighbouring group, but the neighbouring group carbonyl over here. We'll see examples of both in a minute. So it's highly reactive. There's not a lot we can do about beta-lactam. That is just how it is. But we may be able to play around with making the system less acid labile and less prone to self-immolation. So here's a problem of self-immolation that we see here, where, as I already mentioned briefly, this neighbouring carbonyl here can feed in, so electrons can come off there and open up this unusually reactive amide to form this 5-membered ring here. So you have a new molecule called a penicillic acid. From that penicillic acid is it's not very antimicrobial. So one way to get around this, I'm sorry for the poor quality of these slides just here, is to add electron withdrawing groups onto the side chain. Remember, this is our R group here, but I said before we can play with. The original version of penicillin was benzyme penicillin. But if you change a benzene to a phenoxy, as I've just shown here, you obviously have it, and you can withdraw electrons from a ring, and you make the system much less susceptible to self-immolation, and also less susceptible to acid hydrolysis generally. This is phenoxypenicillin. It's also called penicillin 5. Okay, moving on to gram negatives for a moment. When designing and thinking about drugs in general, gram negatives are much harder to kill with antibiotics than gram positives. And until fairly recently, it's been less of a problem. But the primary clinical pathogens have been gram positive. But the gram negatives are starting to make a comeback, or make their presence felt more and more. And Pseudomonas aeruginosa is one of the very important gram negatives. It's an increasing cause of problems in the hospital environment. So just a quick reminder, this is what we're dealing with. It's outer membrane here, and then we have a thin layer of peptidoglycan there. And one of the primary problems of gram negative is we have this extra barrier that to get our drug to where we need it, i.e. to interfere with the peptidoglycan ring, it's much harder. We have a barrier there, and we're relying on pore-in channels basically to transport things in and out. And if the molecule is too big, they won't get in there. So this permeability problem is hopefully clear. You have this outer membrane that just adds another layer of kind of protection around the bacteria. Another issue is something called transpeptidase. Gram negatives have high levels of transpeptidase sandwiched between the two membranes, which means you need to have a higher dose of your drug, your penicillin, to inhibit it. Otherwise, you won't get sufficient inhibition. And finally, third problem is that there's also they often also have an enzyme called beta-lactamase. Again, we'll come on to this in more detail soon. Beta-lactamase is an enzyme which basically breaks down beta-lactams, and it's a beta-lactamase production has been almost evolved due to selection pressure for overuse of beta-lactams over the last 70 odd years. So when developing new penicillins, there's things we can think about doing. Whilst always keep in mind our SAR, our structure-active relationship. In principle, we can add hydrophobic groups, and that has an advantage that, in principle, you may be able to improve the ability to access bacterial membranes, but it appears to, unfortunately, doesn't improve gram-positive activity. You could add on hydrophilic groups, which don't have much effect on gram-positive activity, but by making molecules more hydrophilic, it appears to increase activity against gram-negative bacteria. Why this is the case is not quite clear. So here's a table of some of the side chains commonly used in both natural penicillins found in nature and non-natural synthetic analogues. So there's benzyl penicillin that we mentioned right before. This is I think the original penicillin as first discovered, but it is It can't be given orally because it's acid labile. Whereas phenoxypenicillin, what we discussed, the phenoxy group there, and the advantage there is because of electron withdrawing components there, you can give it by oral administration. It survives the acid in the stomach for long enough to get through. Other possibilities that you might want to consider are ways to shield your antibiotic, your penicillin, from enzymatic attacks such as beta-lactamase. And we'll look at examples probably in the next lecture. So methicillin is an example of this. It also has electron withdrawing groups there on the ring. And indeed, as a whole, there's some very kind of fancy new variants of penicillins which are now produced, such as flucoxacillin, where you have fluorine groups on some quite complex side chains out here. So remember, these side chains all refer to these R group over here. So penicillin's defined by acid stability, is what you've seen. Some acid labile, which is generally speaking not what you want. And some acid stable and can be given orally. And in general, you want to give drugs orally. If in most cases, although if you need to get a drug into someone quick, an IV administration, an IV bolus can be will often be done. So, for example, in suspect meningitis, for example, penicillin is often used, or penicillins is often used, so effective against Neisseria meningitis, which is of course meningitis. But you want to get it back quick, so you give it by straight into the bloodstream rather than waiting for metabolism through the stomach. So all are absorbed following parenteral administration, which is by injection. Apparently injections can be painful and they're widely distributed. One problem with penicillins generally is, to make sure you're all aware, some people are allergic to them for reasons which it's not quite clear to me. So it can be hypersensitive and people can end up suffering from anaphylactic shock. So if you are penicillin allergic, you should have one of these bracelets that tells anybody who finds you that you should not be given penicillin. And then just to discuss briefly the carbapenems. The carbapenem is another class of beta-lactam. They have the same beta-lactam ring we see before. But with a 5-membered ring, but it doesn't include the thiol group on this position here, but still has the acid group here. The carbapenem is often called antibiotics of last resort, and they're often kept on the shelf until needed. They have good broad spectrum activity against gram-negative and gram-positive bacteria, but there are now issues with evolved resistance